So hello and welcome to the ARMA annual lecture. My name is Sue Brown and I'm the Chief Executive of the Arthritis and Musculoskeletal Alliance, ARMA. ARMA's vision for musculoskeletal health is that the MSK health of the population is promoted throughout life and that everyone with an MSK condition receives appropriate, high quality interventions to promote their health and well-being in a timely manner. And we bring together patient and professional organisations across the breadth of MSK to work towards this vision. In January 2020, I met the then very new National Clinical Director for MSK, Andrew Bennett. And we very quickly realised, I think, that we had a very similar vision of where we want to see MSK health going. And he was maybe using slightly different language to the ARMA vision, but it was very much along the same lines. I think we also knew that we were a very long way away from that being a reality. Neither of us was expecting what happened next, which was, of course, global pandemic. During that pandemic, responding rapidly, creatively, and in partnership became absolutely essential to providing the best that could be provided for people with MSK conditions. And don't think it's a criticism of any of those involved in MSK services to say that people did not get what they needed and many are still not getting it. And behind every statistic about waiting lists is someone who is waiting in pain with their life, not able to live the life they should be living because they're not getting the treatment that they need. A lot of partnerships and relationships were built during that year. And it gives me great pleasure to invite Andrew Bennett to introduce tonight's event. Andy is a consultant MSK physiotherapist and is the National Clinical Director for MSK. And he's going to briefly outline how he sees those partnerships that were built during that last year, moving us towards being able to deliver best MSK health. Andy, over to you.
Thanks, Sue. First challenge is to try and share my screen again. So let's get that up. Can we see? Good. Sue, is that on the screen?
Is that on the screen?
Yeah, it is, Andy.
Fantastic. Okay, well, great honour to be invited to introduce this session, which I think is going to be a really interesting discussion from amongst involving four experts in the MSK field who I've had the pleasure to work very closely with over the last year. And what I aim to do is just give a really brief introductory overview of the direction of travel, very much encompassed with our new emergent Best MSK Health programme. As Sue mentioned, these slides will be made available, but please accept this is a programme that's moving very, very rapidly in a very complex context. And so the nature of the slides and the content in the slides is likely to evolve rapidly too. So although shared, this will develop further. So if we reflect first and foremost on the challenge, so we have a triple challenge ahead, I think it's fair to say. And we can break that down to pre-pandemic and consequent to the pandemic, and then making the best use of the experience we've had over the last year. So pre-pandemic, a year ago, and it feels like a very long time, we had a challenged MSK system. I think, you know, it's fair to say we had rising demand, constrained resources and increasing complexity. And there was an unwarranted variation in commissioning, access and delivery of MSK services, resulting in complex provision, which is fragmented or was fragmented and variable. And this was one of many factors driving inequalities in MSK health. We then have gone through a horrendous experience that's touched the lives of everybody over the last year. And our response to the pandemic, which was characterised by supporting surge capacity for COVID-19 cases, maintaining urgent emergency pathways and reducing transmission, has created some unintended consequences. First and foremost, MSK conditions are driven by pain, as I'm sure everybody here is aware, Pain is driven by multiple factors across a biopsychosocial spectrum, and we've been through a pandemic that's affected the lives of everybody physically, psychologically, and socially. So it's fair to suggest that the complexity of MSK conditions is likely to increase as a consequence of the pandemic, and certainly in my day job, that's what I'm seeing on the ground anecdotally. So as well as that complexity, we've got a workforce that has been significantly challenged over the last year, and resources that are stretched to meet new needs around social distancing. Of course, we also have a significant challenge with regard to waiting times due to the pause in interventional procedures as a consequence of the pandemic, and that's waiting times for outpatients, diagnostics, and secondary care interventions. And taken with the pre-pandemic challenges, this has the potential to widen those health inequalities in MSK. However, I think through the response over the last year, the MSK world has united fantastically, and stakeholders, charities, third sector organisations, arm's length bodies, groups within NHS England have united and collaborated to produce our response to the COVID pandemic. And this has also resulted in a significant co-productive approach, working with Christina, and I think driven by Christina, making sure that we are engaging those with lived experience in this response. And it's been built around a model of integration, which I'll come to. And I'm sure all of us on the ground have rapidly introduced new ways of working. And so we've got the opportunities that come from co-production, collaboration, and integration to help support this challenge we have for MSK. And as we move out of this response phase with the benefits of the vaccination into a restoration phase, we are in a unique position in MSK that we weren't at a year ago. And I remember the conversation Sue and I had over coffee as we first introduced, that we now have a programme within NHS England and Improvement called the Best MSK Collaborative. And the ambition of that programme is, through recovery, we want to improve the quality and value of MSK provision to enable best MSK for health for all. We are not rebuilding to where we were a year ago. We want to recover to a new normal, in part to address the challenges associated with the pandemic, but also to really get our teeth into those pre-pandemic challenges also. Now, I can go on at length about the Best MSK Collaborative, but I think it's best, there's a link on the screen. We presented a launch for that a few weeks back, and for further details about the introduction of that collaborative, I'd suggest having a look at this, this launch, which is available on YouTube. But key to it, and key to our strategy moving forward, is this model of integrated MSK working. And we applied this model to our response, and this is key to our overarching strategy for restoring and improving MSK services. And so this is based on the fundamental principle that I alluded to earlier, that musculoskeletal conditions are driven by multiple factors across the biopsychosocial spectrum. It's also built on a population health approach and a preventative approach, and also an understanding that we have heterogeneity in local population and resources. What we don't want is a heterogeneity in outcomes. The majority of musculoskeletal conditions can be effectively well managed in primary and community care. We need to get those patients who need to get into secondary care for outpatients, diagnostics and interventions in a timely manner. And we need to encompass those interventions in the right rehabilitative approach to enable people to have their best MSK health, which essentially helps people age well, work well, and age well, work well, and grow well. Now, of course, taking the principles of the biopsychosocial framework, this model has to align with health and social care and mental health services also. And this is a model of delivery for MSK services, trying to move away from a siloed-based approach to MSK to an integrated approach aligned with the principles of triple integration. And it's absolutely key for us to achieve our ambition to deliver high quality, high value services. Now, we have different models. We do MSK different at local and place level, and there is variance in the quality of that delivery. There should be heterogeneity in how we do things locally because populations differ, resources differ. What there shouldn't be is heterogeneity in outcomes. And the idea behind this model is it's a set of principles that can be applied by local leads who have that best understanding to adapt local provision to optimize integrated working. And on that model, we can hang various guidance documents, but also pathways for specific conditions across mechanical conditions, spinal conditions, inflammatory conditions, connective tissue conditions, osteoporosis related issues, and conditions characterized by widespread pain and fibromyalgia. We can hang those pathways on this delivery model to try and optimize what we're delivering. Now, this is a driver diagram. Sorry, bear with me. One of the consequences of the pandemic is home working and children and dogs, and my dog's trying to climb out the window. So if I suddenly run over there, that's the reason why. Driver diagrams have revolutionized my life, essentially. And what this is a very wordy slide, but I want to draw your attention to the yellow bits, essentially. So our vision for MSK is to promote lifelong best MSK health across all communities. And our aim is to deliver evidence-informed, personalised, high-quality, integrated healthcare of value to all. And we broke that down, working with leads for our work streams within our programme, who are in the column in the white, but also met people on this call and leads from PHE, Health Education England, our charities, and those with lived experience, to identify the drivers to achieve that vision and aim, to formulate priorities. And these are the overarching priorities as it stands now for our programme. We want to adopt an overarching preventative strategy supporting the health and well-being that takes into account health and social inequalities. We want to support the vast majority of people with MSK conditions to live well within the community through a personalised care approach. We need to facilitate timely and appropriate referral to diagnostics and secondary care, and use this integrated model to drive the best use of resources to address the significant challenges we have, such as those with the waiting list. We need to control, and we need to ensure that with a system that is saturated and challenged, that we're getting the right patients in a timely manner, but we're making the best use of our secondary care resources to deliver on the waiting list ask. And then we need to drive this by data collection and to show that integrated models of delivery are working locally to deliver the best quality and value. And we've got good data in secondary care, but I think there is work to be done on data for primary and community care, which is where the vast majority of our patients sit. And through these priorities, we've developed the work streams on the right, which are led by expert specialists in the musculoskeletal field, to drive forward this work aligned with these priorities to try and deliver the right guidance and pathways across this integrated model of delivery. And so how are we going to take that strategy and sort of translate that down to the ground? There is a traditional model that we're all aware of top-down. So it could also be, you can view that as a bit of a square peg in a round hole, i.e. from the top down saying, we must do this, we must do this. There is a need for a top-down model of confidence and engagement, working with the regions, the PCNs and the ICSs to agree a local approach and deliver on our restoration ambitions, our vision and our aim. But that top-down approach won't work on its own. We need this bottom-up approach of ownership. We want to deliver MSK services that are valued by all. The only way we're going to do that is have all involved in how we deliver them, in how we put together the resources within this programme, how we review and progress, and how we design. And so we've got to balance this top-down model of competence with this bottom-up model of leadership. And right at the heart of this is co-production. We have to make sure that we're delivering on what matters to our service users and our patients. And so co-production has to be the heart of what we do. If we are going to have provision that is valued by all need to feel involved in what's going on. And so where do ARMA fit in this? Sue and I met properly a year ago, and we're probably talked virtually daily since over the last year. And it's been an absolute privilege to work with Sue and to work with ARMA. And the role of ARMA within the response over the last year, but within this programme cannot be underestimated. We are a wide family of professions, clinicians, charities, conditions in MSK. And what ARMA have done fantastically and continue to do is help bring that family together and ensure that we are getting input from everybody involved within this program, and also that we can feed back down to everybody involved. And I'd like to thank Sue and everybody in ARMA in helping support that over the last year. The other challenge we've had is around sometimes publishing things. Obviously, we were able to publish things very rapidly in the initial context of the pandemic. But the ARMA website, and I've talked a lot on social media about the massive value the ARMA newsletter brings, but the ARMA website has been a great place for us to share useful documentation to help support the MSK world in the current context. And two examples are here: the urgent and emergency musculoskeletal conditions document, which came from our specialist guidance document produced in the pandemic, but also the principles for COVID-19 vaccination and rheumatology, both of which have been co-produced by multiple stakeholders, and I think are of huge value and sit on the ARMA site. And so we will be working and are working very closely with Sue and ARMA moving forward around what I think is fair to say is a shared vision and a shared aim. And so this is a brief summation of where we are to date. This has moved very, very quickly over the last 6 to 8 months. To paraphrase one of our workstream leads, Chris Mercer, we are building planes, we're flying it, and we have a clear vision, a clear aim. We have a significant challenge, but we have a significant opportunity. And what we're looking to do is work with everybody in the MSK world to try and meet the challenges we have ahead, which are significant, but utilise this opportunity we have of a programme for MSK and significant resources, certainly with NHS England improvement, to drive forward our restoration and improvement ambitions. Thank you for your time, and I really look forward to further questioning with this within this excellent panel.
Thank you, Andy. And if the other panelists would like to put their cameras on now, we are now going to have a fair bit of time for a bit of Q&A and panel discussion. If you want to use the chat function, please do make sure that you have changed it to panelists and everyone, so that everyone can actually see what you're saying, and not just the panelists. And if you've been struggling to see those slides, as I say, they will be available on the ARMA website soon after the event. But I'm now just going to very briefly ask each of the panel members in turn to introduce themselves and say very briefly where they see themselves fitting into the work that Andy has just set out. So I'm going to start with Amanda Hensman-Crook, who is AHP National Clinical Fellow at Health Education England. Amanda.
Thank you. And also I work as a consultant MSK physiotherapist as well. So I do a couple of days clinical as well to keep my feet on the ground, hopefully. From a Health Education England perspective, where I fit in with this is around capabilities. So I work on making sure that the capabilities and proof of capability is correct for first contact practitioners for MSK and for advanced practitioners. I'm also looking at some consultant framework work and also the bit below advanced practitioners in MSK for the enhanced work, but largely mostly first contact and advanced practice. And that's for the patient's safety and for clinicians' safety across the system.
Brilliant, thank you, Amanda. And Nuzhat Ali is National Lead for MSK Health at Public Health England. Nuzhat, do you want to say very briefly where that fits into this picture?
Thank you, Sue. So I think it's important to highlight that just over 2 years back, Public Health England with NHS England and a whole range of other partners and stakeholders, including ARMA and Health Education England, we published a 5-year prevention strategic framework. And a lot of the work that's within that framework, as the Best MSK program evolves and develops and strengthens, the aspects of the prevention from that framework will be embedded, and we'll be looking to ensure that that is implemented through the programme of work that NHS England will be carrying out, specifically around prevention, right through from primary prevention, secondary and tertiary. So it's threaded throughout all the work that's being delivered as we go forward. And in addition to that, one of the other key things, and Andy's mentioned it in his presentation, it is around ensuring that we have a razor sharp line of sight on how we're impacting the inequalities that we know exist within MSK.
Thank you, Nazat, and I think we'll come back to prevention during the discussion. But finally, I'd like to ask Christina Thoreau to introduce herself as the Lived Experience Ambassador in the Experience of Care team at NHS England and NHS Improvement. Where do you see yourself fitting into this picture, Christina?
Well, job title says it all, really. Lived experience. I'm very much still living that experience. I've got multiple chronic MSK conditions, and for me it's very much it's been quite an eye-opener. It's been a great way of working with all of you, but for me it's having that lived experience, working alongside what I call the learned experience of the clinicians. Of course, lots of us have both. So it's that bringing in that patient voice, but being able to be that connector. So we have a MSK lived experience group, and I think it's really important that we maintain that local commitment to not just do the national, but actually having people out there that are on the ground, that have either as patients or carers, have that connection into the community. So I think it's really important that we maintain that co-produced way of working. And I also co-lead the patient and carers work stream, beneficial changes, which has been really important in this piece of work as well.
Brilliant, thank you, Christina. So this is our panel. I don't want the whole of this evening to focus on the recovery of backlogs of care. However, I'm going to start on that one. And we've had a question about this. So the Prime Minister said on Friday, we're going to make sure that we give the NHS all the funding it needs, as we have done throughout the pandemic, to beat the backlog. We're going to do whatever it takes. So what does the panel think is needed to beat the backlog? Who would like to start with that one?
Go on, I'll take the plunge. I'll come back to integrated working and productivity. There is a lot of work ongoing at the moment, which we are all involved in trying to address this problem. We have a significant challenge with regard to backlogs for interventions, but also for other things like diagnostics and outpatient appointments. And we've got to think about that in terms of a cross-framework MSK approach. Now that means we need to ensure that we still get the right patients into secondary care in a timely manner. When there is a system that's saturated, urgent and emergency conditions still need to be recognised, managed and got in to optimise outcomes. We need to ensure that we are, and I use this word carefully, but being as productive as possible within secondary care settings to maximise the use of our resources to deliver the interventions we need to deliver, but accounting for a workforce that is challenged and fatigued, but also a population that's challenged, that's been fatigued. We also need to communicate effectively with people who are waiting to keep people up to date about the scenario we're in, and also support those people whilst waiting to manage symptoms as best as we can. It is a significant challenge, which is multifaceted. And one of the reasons we have this Best MSK programme is to help address that challenge. And there is a significant amount of work in a lot of different, across a lot of different programmes with NHSE and I, looking at how we can do it.
Thanks, Andy. Christina, where do you think the patient voice fits into this question?
It's exactly where I was going to put my hand up. So we've really got to understand about personalised care. I believe that actually shared decision making and supported self-management is key here, because there might be a big backlog, but without speaking to your patients, you're not going to know actually what the person's circumstances are, whether they are still wanting that surgery, if it's surgery that they're waiting for. So we have lots of different lenses on this. So for myself, I was shielding for a year. So for me, I definitely am deconditioned, and I have an amazing relationship with my surgeons. So therefore, that already have that connection, but a lot of people don't have that, or they're experiencing MSK conditions for the first time. And I think education is very important, having information available to people. That's why the ARMA website's, absolutely amazing for the, sharing information on. And I think, in terms of the futures platform that we're building for MSK, we'll be able to share information across the board, because there is a level of inconsistency. I'm not going to pretend everything's great, because it's not, and there is a level of inconsistency. But what we are doing, working really hard, is to try and see what does work well, and how people can look at their own communities. But I think it's really important to find that lived experience within your own areas, because each community has its own different needs, etc. And I think that's really important.
Thanks, Christina. I don't know if Amanda, did you want to add something to that?
Yes, I think so. So as Andy says, it's a huge challenge ahead of us to get this right. But to make sure that it's right, and we need really good leadership. And to have the right leadership, then we need to make sure that the leaders have the right capabilities, so that they have the right impact across the system. So it's really important that we make sure that the capabilities are standardised and they're in place, so that we can make sure, from consultant practice, advanced practitioners across the whole system, working across all professional groups in MSK and working across the whole of the system and in each clinical setting, that the leadership's there to provide that change, to help turn this big ship around. But you also need the enhanced level practitioners and the practitioners below that, again, with the right level of capability, so that they can help provide the right level of care clinically to these patients as they're going through the system. Because it's about, we know that we've got a lot of deconditioned patients, and we know we have long waiting lists. So in terms of primary care, we need to make sure that we've got the right people at the front end, so that they can look after the people whilst they're waiting on these waiting lists, and to know when to filter them through pathways. But we need to make sure that that integration through the whole of the healthcare system for MSK is right. And by doing that, we need to make sure that the right people are there at the front and right the way through the whole of the healthcare system for MSK.
Great, thank you, Amanda. Nazat, I don't know if you had anything to add on.
Yeah, so the only other thing that I would add on is really, well, one is around sort of where we know the evidence of what works. So I'm thinking around some of the secondary interventions. The Public Health England published about 4 years back now, return on investment on interventions that work. So we want to see more scaling up of the interventions that work. So it goes hand in hand with what Amanda is saying, that capability and knowing what the interventions are that could and should be scaled up in the community. And the second is that the recognizing that this is a whole system wicked problem that will only, the ship will not turn unless we're working collaboratively together and really sort of working in those integrated ways. So that would be something that, as we go forward, that we need to really focus on. And I know that process has already started in local and regional areas.
Brilliant, thank you. So I'd like to move on, kind of looking beyond just restoring the backlog. I know Andy said we don't want to go back to what we were before. We're much more forward looking. We've had a number of questions asking things like, how do we know we're making a difference? What should we be measuring? What should we be looking for? How is this different from other things that NHS England or others have done before around improvement? So any thoughts on that? How do we make sure this is really driving us in the right direction? and
So
that sort of difference. Andy, do you want to start?
yeah, really, both really valid points. You know, I've been NCD for a year, but as a clinician and as a consultant practitioner in Southwest London, I've been involved in a variety of different strategies to improve MSK delivery. How is this different? Well, I think first and foremost, the nature of resource we have at a national level is significant for MSK because we have a programme and we have significant work streams with expert specialists leading, and we have resource within that programme to help us deliver change. And that is a unique position for MSK that we've not been in before. I think the other difference is that MSK as a family has come together, I think, very much over the last year. And I think prior to that, there was lots of great stuff going on. But was that stuff in sync? Was this a machine where all the cogs are working together? Possibly not. Whereas now I think we are in the position where we are. And certainly within NHS England, we're working very closely with Sue, our charitable stakeholders, the different programmes involved in MSK, with Amanda and Nuzhat, around a shared vision and a shared aim. And I think that is a unique position. The other thing at the heart of that is the co-productive ethos we've got, which I think we've led the way on, and having what matters to patients as the focus of what we're doing is absolutely key. So it is a different scenario because of the resource, because we've been through a very, very challenging year that has led to the position we're in. And it's also, I think, another difference is the model of delivery and pathways. Before, and certainly previously, I've been involved in silo-based improvement structures at work, or in bringing out pathways. But the challenge we've got is the heterogeneity in delivery, and sometimes those pathways don't fit with how local services work. One of the differences, I think, is we're splitting those things. We're focusing on the model, and we're focusing for which enables that heterogeneity and enables, my ambition is to enable local leads to lead. And as a local lead myself, that's what I'm looking for, that we can then hang a lot of the pathway work, which we've already done on, to deliver what we want to deliver. And so I think that's a different way of looking at things. I think we're far differently resourced. We are in a far different collaborative approach. And I think that this integrated model is key. And that enables us to build on the excellent work, you know, Nuzhat reflected on the PHE 5-year plan, it's brilliant work. So it's enabling us to build on that and bring it all together as one. And I think that's what's different. The other bit, I'm afraid I got lost there and I've forgotten what the question was.
What are we going to measure and how do we measure it?
Oh yes, absolutely. So absolutely. So we need to measure the effect and we need to measure the output, but we also need to know where we are. And I think it's fair to say that our ability to measure quality and value in MSK at the moment is variable. I think we do it very well in certain pockets. Examples relate to audits for inflammatory arthritis and secondary care work and right care work. And of course, we can pull holes in all these things, but it's still measurable data. I think we are lacking a bit in primary and community care with regard to our ability to measure MSK data. So that's why this is a key priority for this work stream. And then it's also about collecting data, but defining it and using it well. Data's there, it's just how we use it. So then it's measuring the right things. So what we're trying to measure is quality and value. So we need to take a population health approach. We need to measure the impact of MSK conditions on people's lives and the lives around them, which includes patient experience measures as well as outcome measures, as well as measuring traditional things such as waiting times, etc. So we need to have measurement tools, a collection of measurement tools, so we can fully evaluate right across that integrated model how effective we're being. And then if we can do that, then we can create a learning system that evolves and adapts.
And Christina, I think you wanted to come in.
I just want to say, you know, so I work for the Experience of Care team, which is traditionally known as the patient experience team. But the Experience of Care team, it's looking at different measurements, not just waiting times, etc., but actually looking at each of the communities that if you're looking at your local community and what's important to that community, then you'll be able to have like your prems and stuff, asking the right questions. But it's not just about collecting data, it's what you're doing with that data, and actually looking at involving people within your local communities with lived experience, so that actually you can have those really transparent, open conversations. And I think lots of people don't like change, but I think we've had a situation where everybody's having to work in a very different way. So I think right now there's a very even kind of footing that everybody's got lived experience of COVID. So it's the right time and it's the right opportunity now to actually strip away the kind of power between people in terms of co-production, and actually working together in partnership, which we've modeled that, we've experienced that over the last year. But just recognizing there are really good integrated like MSK systems out there that are working, and some people may recognize me. I used to be the Camden MSK patient director, and actually working together with your local communities, working together with your third sector and your the local authority makes such a difference. And I've witnessed that at trust level as well, and I think that's what's really important is looking at them partnerships locally.
Great, thank you. And we've had one or two questions coming in about that kind of the prevention angle. So I wanted to ask Nazat, where do you see that fitting in? Do you think this is different from what we've seen before? And we also had a question about a lot of talk up till now has been about NHS services. How much is there also a role for the individual in keeping themselves healthy? What's your take on that, Nazat?
Yeah, it's absolutely critical. It's really key. I mean, the thing is, if we don't focus adequate resource capacity and focus on prevention and preventing people from actually, many of these conditions are preventable, then the stream of people is just going to keep coming in. We need to stem that stream, and one of the key ways we know is through prevention. And therefore the conversations that we've been having, Andy, within our work stream meetings, is to ensure that the prevention angle is absolutely embedded in everything that happens in all the work streams. It's absolutely core and critical, which then means making sure that the staff and the workforce actually understand what that means. So, people that work in the health service, that one of the approaches is the making every contact count. We know that it works. The evidence is very rich. So how can we use that approach in not just MSK services, but other areas as well, around the prevention agenda? And then I think there was another question around self-management. Whilst there's this very, very long waiting lists and people are having to sort of to wait to get to be seen, I think it's critical that the NHS and local authorities and other stakeholders that are in the integrated care systems can offer and provide support for self-management around physical activity, around healthy diet, smoking cessation, and a whole range of other healthy lifestyle advice and interventions. And I mean, Public Health England, obviously our lifetime is short. We've got until the end of the year, but we will be transitioning into the Department of Health, and some of the functions will be moving into NHS England as well. So there are a huge number of resources, and there are partnerships out there at local level that we really need to make sure that they're well equipped with the resources and with the skills to deliver on the prevention agenda. It's absolutely vital, because if we don't take this opportunity, and especially I think COVID-19 has really brought the whole aspect around health and well-being to the forefront of not just politicians' minds, but people's minds as well. So it's an opportunity for us to absolutely sort of really promote healthy well-being, not just physical but also mental well-being as well, because we know there's a very close intrinsic interaction between mental well-being and physical well-being.
Brilliant, thank you. And you mentioned the skills around prevention, and Amanda, I wonder if you've got any comments on ensuring that healthcare professionals have the skills to deliver that prevention agenda, and rather than just the skills to do treatment well.
Absolutely. So it's in the heart of the advanced practice MSK standards. Is that prevention part is a really big section actually that runs through the thread right the way through the advanced practice MSK standards. So you all have to prove capability around that, which means there will be an element of learning that will need to happen for you to be able to provide a portfolio of evidence to do that. And the same for first contact practice, which is a subset of those standards. So the first contact practice, part of the advanced practice standards is the clinical pillar, and within that clinical pillar sits the core primary care capabilities. And the core primary care capabilities is all around personalised care, and it's about all of that we've just been talking about is part of that. So anybody that's either training up to work as a first contact practitioner or an advanced practitioner across the whole of the system in MSK will have that training. And also in terms of the roadmaps that's landed, the personalised care modules are a mandatory part of that. And the other mandatory modules for primary care that are in there that the clinicians will need to do also have all of these learning elements, and it's absolutely critical. We're also developing a e-learning for complex clinical reasoning that will be at different levels building up to master's level of practice for MSK, and that's also got elements in there. Now this particular e-learning is really exciting because it's not just sitting down at the computer and doing e-learning. It's really important that there's an interaction with the supervisor as well, so it's going to be like a blended approach. So by having that experienced clinician, there'll be tasks that have to happen before they can go on to the next step that the supervisor will open. So there's a lot of really exciting things in terms of making sure that we've got this right for that element outside just the MSK part.
Brilliant, thanks Amanda. Christina, did you want to come in on the prevention angle to this?
I had my hand up by mistake there, sorry.
Sue, can I just add something? I'm just looking through some of the questions there around the prevention and data and the workforce, sort of trying to bring them together. That whilst we're working in communities, it's really important that staff are, the workforce are equipped to understand where and what the data is telling us in terms of inequalities and be able to intervene and target better, because it's not, so depending on the communities, depending on the geography, gender, ethnicity, etc., different approaches may be required when looking at access, for example, or prevention resources. So there's something around when we're looking at the workforce, how skilled are they in terms of identifying inequalities, but how well are they equipped to then be able to tackle and deliver and intervene appropriately as well.
And this is where I would like to step in. It's just for me, what's been really beneficial personally, and to lots of people, and I know some that are on this call, is peer support. And so actually, whilst being in Camden, I was quite fortunate and met a patient-led pain support group, and actually that peer support to help people to do self-support. Self-management is difficult, especially if your mental health is quite taking a bit of a blow. You haven't got your support networks around you, and I really recognise that personally, been there myself. So for me, it's keeping it real and making sure that lived experience voice is always in there, so that people recognise it isn't, they're not separate things, and we must think about a person as a whole. And absolutely, the inequalities, without a doubt, it's something that we really need to look at, and why some people don't come forward until actually they're at a stage where the MSK condition is at a stage where needing surgery, etc., where actually there could have been a lot of work done prior to that to make the person be able to manage, better for longer. And I think we need to look at a person and the whole kind of life situation about why some people aren't willing to have surgery, and not just thinking, oh, they don't want surgery. Well, actually, why don't they? Let's think about people that are in housing where there might not be a lift and you need a new hip. You need to think about those things. And I think it's something that the lived experience group that I'm working with, they bring that reality to the table. And I think that's what's really important when we work co-produce.
Great. Andy, did you want to come in on that?
Yeah, I agree with everything that's been said, essentially. But back to Nusrat's initial point, prevention and population health is key to what we are doing and is all-encompassing to our integrated model of delivery. And I think the other key thing, and largely because the vast majority of MSK conditions can either be well managed or prevented with physical activity, managing diet, managing mental health, alcohol moderation, and smoking cessation. And that's key to what we're doing. And then that leads to one of the cruxes, I think, with the challenges we have is to support people. And I struggle with the term self-management. I just sometimes find it a bit cold. What we're trying to do is help people best live with long-term MSK conditions. And that comes back to the growing well and the working well and the aging well. And that's fundamentally key to our strategy, is to support the majority of people with MSK conditions and those who have long-term conditions to best manage those conditions within a community setting through physical activity, managing mental health, through working with the third sector and the social sectors. And that comes back to the question that we answered initially. I think that is a step forward in what we're doing. I think that collaborative approach, working with Nusrat and Amanda and Christina and the multiple stakeholders with long-term condition management at its heart and the personalised care approach about what matters to service users is what we're doing here.
Thanks, Andy. And there's been a question about this, but Nusrat's helpfully raised it as well, which is the question of mental health. So, and this is an issue that ARMA has been raising for some years. We know there's a connection between certainly depression and anxiety and a whole range of different MSK health conditions. But we also know that people tend not to get the support that they need to address those things. So where do the panel think mental health sits in delivering best MSK health? Christina, do you want to kick off?
I'm one person, so for me, if I said it once in an IAP for Talking Therapies celebration, and I said, just like it's all psychiatrists, psychotherapists, and I said, just like you could all go down the road and break a leg, you could all go down the road and have a breakdown. And I think it was a hushed silence that they were quite shocked that I did say something like that. So for me, it's massively important. And I've been very open throughout COVID that it actually triggered the vulnerability of my kind of shielding, and being stuck indoors has triggered my PTSD. So, and with that comes anxiety and the rest of it. So and I think to myself, actually, I'm not the only person that's in this situation. Somebody with a chronic condition, and without a doubt, there's people with complex conditions that actually they don't know which way out, and we need to be looking at that and addressing that, because actually by being indoors, there's lots of factors that can impact on somebody's well-being, and the isolation as well. We need to really look at that, and I think we are looking at how that works across the board. And I think that's what's so important. This new way of working, integrated working, is absolutely amazing, and it's something that long time coming, but I'm kind of really optimistic about it.
Brilliant. Nusrat, did you want to come in?
Yeah, I just wanted to add, really, I think that we all know, and I think we need to grasp the opportunity and treat people as a whole, mental and physical. And the other thing is around multimorbidity, and recognizing that people aren't coming not necessarily with one condition, it's often 1, 2, 3 or more conditions. And so how can we take an approach that actually is looking at that individual as a whole, and recognizing that when you've got pain, that there's a very high chance, I think it's over 70%, that you will have some form of mental health condition, whether that's depression or anxiety as well. And for that to be talked about when people are having their consultation. But again, it comes back to how skilled the workforce is in order to recognize that and to have those conversations, and then recognize, but then also refer to the experts that can then support.
I think it's how skilled and also how confident do they feel. And I'm going to bring Amanda in here since we've mentioned the word skilled.
Yes, I like that word. Yeah, so actually, I would go as far as to say you can't separate the mind and the body. And I'll go as far to say that everybody that has MSK conditions at some level have an impact on their mental health, whether that's a mental health condition or mental health for the period of time they've got it, because it affects everything. It affects their livelihood. Even if it's just in the moment, if someone's sprained their ankle, that still has an impact on their mental health, and they still need to be reassured and given a really careful plan on how to do it. So in terms of skills, it's so important that in terms of the learning and with the capability work that we've been doing with Health Education England, again, the mental health part is integral in it. And in the e-learning modules, in primary care e-learning modules and mental health, that's one of the sets of modules. You can't separate it, and I can't tell you how important it is. And I know that with the Best MSK group, that is something that we talk about a lot, and it isn't separate from the MSK condition, it's part of the MSK condition.
Thanks, Amanda. Andy, did you want to add anything to that on the mental health front?
Look, I think a lot of what I'd say has already been said really eloquently by the panel thus far. I think that the focus is back to the population health agenda, but also that we're trying to help people best manage MSK conditions driven by multiple factors. And some of those are physical, some of them are social, some of them are psychological. And we have to work closely with mental health services to enable that. What we're not doing is treating people as a knee condition or a back pain. What we're doing is treating people as people. And actually, we're trying to help people get back to a full quality life, managing those conditions well, right across that model of delivery. And that's the approach we need to take. And to take that, we have to think of physical and mental health together, because both affect patients we have. And similarly, it's not, I don't really like the word multimorbidity or comorbidity, but a lot of the patients involved, or we see, have multiple conditions driven by a combination of physical and mental health problems. And we've got to think of managing those conditions collectively rather than siloing patients into specific areas. And I think that is, again, another step forward that we're doing. And a good example with that, of course, is we were interviewing today for our National Clinical Speciality Advisor for Personalised Care in MSK, and we've gone out to advert for a similar one for cardiac prevention and respiratory disease. And one of the things I'm excited about with that is actually those new roles working together and thinking about patients and the drivers for those conditions together, rather than thinking within their silos. Because essentially a lot of patients we manage with long-term MSK conditions also have other conditions as well, which are driven by similar factors, i.e. physical activity, mental health, diet, etc. So that is very much at the heart of what we're trying to do. But Amanda is quite right. It's easy to say that. There are lots of things we need to work through in terms of capability and in terms of commissioning and resources to enable that to happen.
Great. Christina.
I just want to mention something. Actually, we talk about people's well-being and mental health being impacted by the MSK conditions, but I also want people just reflect a little bit on people that come in that primarily have been treated with mental health conditions, who potentially haven't come forward at an earlier point, and just recognizing how difficult it is for some people to actually come forward and actually ask for help, and not to judge people for coming in late and why they haven't come in any sooner. I just want people to go away and reflect on that. And it's also, we talk about health inequalities, and I think it's really important. There's one story that stuck with me throughout COVID, and that was of a homeless gentleman who wasn't taken that seriously, and now has been impacted by coproduction, and the impact on his life has been horrendous. And he was already having so many health inequalities, and for me, he will stay with me. I think he will stay with me throughout my career with that thought process of actually, the assumptions of why that person had those pains. And I think it's just going away reflecting actually that we need to be looking at not just the loudest people, but the other people that are giving you hints when they're coming forwards and maybe not telling you the full story, and getting those skills, the ability to communicate with lots of different people.
Great, thank you. We have more questions coming in than we could possibly get through unless we go on till midnight, which I'm not proposing that we do. We are kind of coming towards the end of our time. So in a moment, I will ask the panelists if they have final thoughts at the end of our session, and then wrap up. There's so much here. And mental health has been a big thing that ARMA has worked on in the past, and we have a report of a roundtable on mental health that we did a couple of years ago on our website. We very briefly touched on inequalities, which we could probably have, we definitely could have a whole event on inequalities, because we are actually planning one later on this year. And so there is just far, far, far more here than we can possibly do in a 1 hour lecture. But so just before I kind of wrap up the evening, can I just come to each panelist in turn for your kind of final closing thoughts? I'm going to come to Amanda first.
Okay, I think that my closing thoughts are working together in collaboration is the way forward. If everybody is doing their own separate things, and all brilliant things, like Andy said, unfortunately, if they're not joined up, then there's no move forward. I just feel very grateful that this has happened over the last year, and that we are working in a co-productive kind of way with everybody that's like-minded. And I just wanted to let everybody know that we all have the same vision, and that we are moving together to help you guys, and we will be looking for you guys out there to feed into us, so that we know what your thoughts are, because you are just as important as anybody else who's sitting on this panel, or anybody else in the whole programme of work. So that's my food for thought: better together.
Brilliant, thank you. Nuzat.
Hi, not to echo what Amanda has said, but I think absolutely collaboration, working collectively together, it's absolutely vital. I'm going to just throw something else in, which we've sort of touched on, but we haven't. With the new integrated care systems, I think it's important that we absolutely bring in local authorities and other stakeholders, such as the leisure industry, such as some of our private providers that are providing some of the physical activities services, for example, yoga, for example. It's not available on the NHS, but we know it's an effective service to help people with MSK conditions. So it's that whole system working, bringing people together and thinking about some of the wider determinants that impact on people developing an MSK condition, but then that MSK condition actually then deteriorating, whether it's to do with housing or whether it's because they haven't got the support in the workplace. But in this very sort of collaborative, partnership, integrated way, for us to be thinking about some of those wider stakeholders that we need to bring into the fore and work with as we go forward.
And I think that's a really important point. Once you start talking about population health and prevention seriously, you start bringing in all kinds of stakeholders that are not on this panel at the moment. And I think that's really exciting, as well as a real challenge. But I just want to add one to that list, which is really, really important, which is the patient organisations, the charities that are members of ARMA. They have a huge amount to offer to this programme, and some of them are beginning to be involved in the work streams in a formal way, and I think all of them will be involved both nationally and locally in supporting the programme. So that one is really important as well. Christina, what would your kind of final words be?
Won't be my final words, I'm sure. You never shut me up. But I just wanted to say, actually, I've had free yoga, but not the NHS, by listening to the patient-led pain support group, who actually, by being out there with the third sector, you'll be amazed how resourceful patients are in terms of self-management. And actually, if you're aware of who your patient groups are, then you're more than likely to find out what the third sector's, what offerings there are to people. So there's that. But my final words, I'll be honest with you, 3 years ago, I was chasing you down, Sue, for an invitation to one of these lectures, and never would I have dreamt that not just me, but me representing in terms of lived experience group, would I be sitting here now. So it shows to me the big change that's happening. And I think if there's any patients out there, people that use services, service users, whichever you want to call yourselves, people out there who are really interested, please do get in touch, because we're always widening our network and wanting to hear voices from across the country. So please do get in touch.
Thank you. And finally, Andy, what would your parting words be this evening?
I think firstly, a huge thank you to everybody on this call who have been, I am sure, impacted by the last year. Many will have had their work lives significantly changed whilst juggling personal issues and challenges associated with the pandemic. And, you know, thanks for all the efforts you put in and continue to do. I think also thank you to Sue once again. You're absolutely right about the involvement of all the patient groups as well as professional bodies in the work we're doing, and your expertise in bringing that together and feeding that into our work has been massively appreciated and will continue to be so. I think the key is back to what both Amanda and Nuzhat and indeed Christina have said. We have a massive, we have a massive challenge ahead. We had a massive challenge a year ago. The difference is now is we've got this opportunity of this programme, and the key drivers to that is around integration, around collaboration, and around co-production. And I think if we can, those are for me the overarching beneficial changes that have come out of what has been a massively challenging year for all. And if we can build on that and help translate that locally and enable local leads to do the things they want to do, which is meet the needs of the population and address the inequalities that we know are there, I think we can build something really quite special out of this. But there is a significant challenge ahead, and we are very much at the start of that. And it's again, I used it before, we're building the plane as we're flying it, and there is a long way to go.
Brilliant, thank you very much. And I think everyone would agree that there is a significant challenge out there, but I'm really excited by the idea that we could together build something really quite special. So I'd like to thank everyone for joining us today. I'd like to big thank you to our panel. Thank you to all of our attendees, including the international ones, because we have had at least one person from Canada on the call. So we have gone way broader than just England. So thank you everybody for joining. ARMA, in case you have not come across it, is a very small charity. If you are not already subscribed, I would urge you to sign up to our newsletter, which only comes out once a month, so it will not clog your inbox. But we'll keep you up to date with what we're doing, but also what a lot of our members are doing. And also check out our webinars and our other resources on our website. If you do know of any MSK organisations that are not already ARMA members, please do encourage them to join. And if you like what we do, please also consider supporting us. Please also share the recording of this event. You should all get an email with a link to that recording once it is up and available. And do continue the discussion on Twitter using #BestMSKHealth. But most of all, wherever you are in the system, and by system I include people who are living with MSK conditions, please do what you can to support this drive towards best MSK health, because I think if we can all get behind this, then the future for MSK is potentially very, very exciting. Thank you all very much.